at King's College Hospital in London, and I am chair of the Palliative Medicine SAC, which is the National Training Committee. So thank you all very much for coming and listening to us today. We're here to talk to you about careers in palliative medicine. Before we start, I'm just going to thank Vicky Ong from the PTB for setting up the webinar for us. She is recording the session, so if any of your colleagues haven't been able to join today, it will be available via the palliative medicine page on the PTB website in due course for people to listen back to. For a bit of housekeeping, just so that hopefully it goes smoothly, can I just please ask you to turn your cameras off and mute your microphones? I think everybody's already done that. We've all learned over a couple of years of the pandemic, haven't we, how to do this? We're going to take questions at the end, and we would welcome you to, or please do ask us questions. Can you please put them in the chat? I'm going to be keeping an eye on the chat, and I will then be directing questions to some of our panel members at the end. So hopefully we will be able to pick up most of the things that you want to ask us. Okay, so starting off then, I'm going to give you a bit of an overview about the new curriculum, and then I've got a range of colleagues with me today who are going to talk about life in palliative medicine, both from a trainee and a consultant perspective. And Hannah's going to finish off at the end talking a bit about future consultant posts. And as I said, we're also going to then have a question and answer session, so please do put your questions in the chat. So what is palliative medicine and why might you choose it? So as I said earlier, I'm a hospital palliative medicine consultant. I've been a consultant for nearly 25 years, so I'm starting to feel very old. But what I've really enjoyed is working in a specialty that is very holistic, very diverse. It's always different. There's never a dull day. And I've also really enjoyed working as part of a multidisciplinary palliative care team. So within palliative medicine, we're predominantly seeing people with life-limiting illnesses, not exclusively, but that would make up most of our patients. And referrals to palliative care services in all settings will be based on need rather than diagnosis. We work across all settings. I work in a hospital. Some of my colleagues on this call work in hospices and community teams as well. We take a very individualised approach to the medical care of the patients that we see. So it's very much based on problem solving and trying to think about not just patients' physical care needs, but also the emotional, spiritual and psychosocial dimensions of their care, and trying to address all of them in order to deliver the best clinical care possible. We work within teams and very much also between teams and between settings. I'm probably somebody that's had what you might call a portfolio career. So I've had lots of different roles and responsibilities in all my years as a consultant, and that's been really interesting and has meant that I've never got bored. But I think palliative medicine is unique in that it really does offer you an opportunity to do lots of different things, whether that's leadership and service development, whether that's about policy, or whether that's education and research. So the new training pathway looks a bit like this. So from internal medicine, which is 3 years stage 1 training programme, there's then competitive entry at ST4 into the specialty training programme across 4 years, and that's integrated with internal medicine. So why are we now training with internal medicine? That's a good question. So the type of work I do as a palliative medicine consultant over the last more than 20 years has changed enormously, and that's because our patients are becoming far more complex, and there are lots of different reasons for that. But we're increasingly seeing people with multiple long-term conditions, including frailty and potentially including cancer, and people are living a lot longer with long-term conditions and life-limiting illness, and that leads to them having far more complex needs. We're also seeing in many conditions increasing treatment options, which is fantastic. So people live longer, but they don't necessarily live longer well. And we're also beginning to see the multi-system complications from treatment. And all of these need expertise around holistic, individualised care, including expert symptom control. And that's what in palliative medicine is one of the key things we're going to be doing. I've also had to really learn my general medicine again and really build on it and update it in order to be able to work in a hospital setting, because the patients that we see are so complex and I need to understand the reversibility of different clinical situations in order to do my job. So our patient population has changed. That's made it more complex, and that's why we need the medical skills. But we also hope that wherever you work, so even if you end up working in hospice, if you end up working in community, you're going to need those enhanced medical skills to best meet population needs and deliver safe and expert care. And that's going to include thinking about how do we best deliver complex care in the community, and what do we need to do in terms of the hospital community interface to best meet the needs of patients going forward. So we feel that the dual training will better equip you to do that. Having said that, there are lots of similarities between the new curriculum and our existing curriculum, which was written in 2010. So we're still going to be training doctors across all of the palliative care settings, including hospice, community and hospital. It's still a really broad approach to training based on our principles of needs-based assessment, holistic assessment and individualised care. We're still going to teach you about the core knowledge and skills you're going to need in order to be an expert palliative care physician. The curriculum remains flexible to meet individual training needs, so that you can start building on your areas of specialty interest. We're really committed to still delivering high quality supervision and supporting you to work in really, really supportive, close teams, which I know a lot of you don't experience in IM training. And we will still have the SCE, so that's the Specialty Certificate Examination, which is our knowledge-based examination. There are, of course, some differences. So we've talked already about the fact that it's dual training with internal medicine. So indicative 4-year programme, around of which 25% is going to be spent in internal medicine. We've put much more detail in this curriculum about what we're expecting from you guys as doctors in training in order to meet the capabilities and practice in the new curriculum. And that's including what are the skills that we're expecting from you by working across the different settings and by participating in specialty on call. So you'll all be familiar with SIPs already through the internal medicine curriculum, but we've really expanded those in our specialty curriculum to try and explain better what we're expecting from you at the end of training. We've put in enhanced recognition about the changing population needs and the demographic changes that mean that palliative medicine as a specialty has changed. We've put in much more about the new concepts around public health, palliative care, including health promotion and at the end of life, and also thinking about the use of resources such as compassionate communities to deliver sustainable services going forward. And also, as alongside that, we've thought much more about technology and also what do we need to do to support you guys as developing clinicians around self-care and resilience so that you can continue to have fulfilling consultant careers for many years. I'm now going to hand over to Kathy to talk a bit about what the training programs are going to look like. Kathy, you're on mute.
There we are. I managed camera but not sound. So good afternoon. I'm Kathy Gleeson. I'm a consultant in St Catherine's Hospice in Sussex. And alongside that, like Polly, I've had a varied career and I'm currently one of the training programme directors for specialty training. So what I wanted to talk about was what actually the training programmes will look like with our new curriculum. So there are, to be fair, a range of models across the regions, but all of them are interweaving internal medicine and palliative medicine. So as you've heard, it's 25% internal medicine, and generally speaking, we're looking at doing that in blocks. But we're aiming for local links between palliative care units and acute hospitals in order to try and smooth the transition between the two. And probably you'll find that if you apply for this, you'll spend some of your early time in a palliative care unit. That may well be a hospice, but it may also be a hospital palliative care team. The thing about the blocks is that they are interwoven with the palliative care experience, but the important thing is that there will always be internal medicine experience in the final year, so usually 3 months, although this might be an immersion month in the acute medical unit. The honest truth is this is an evolving picture and we want to do our best for those who are working flexibly or taking time out of programme to do other things. And so we will probably see adjustments to exactly how the internal medicine and palliative medicine are interwoven over the next couple of years. But the aim is to ensure that you remain confident and competent in both aspects of medicine as you go through. So these are two samples of models. They look slightly different, but really I've put them there to just highlight that there may be some variation in how the training programme looks. So we would really encourage you, if you're interested, to speak to the training programme director in the region where you might be applying to find out how they're doing it there. These two samples show blocks of 4 months of internal medicine and the lower one blocks of 6 months of internal medicine. And you can see that the experience in palliative medicine is between hospice, inpatient care, community care, and hospital palliative care teams, with possibly specific interest in oncology if you have blocks in oncology centres. So the main thing to take away from this, I hope, is that the internal medicine and palliative medicine experience is interwoven and complementary. So please don't think of it as two large separate things that you would be tackling. They are interwoven and relevant to one another. So because of the patient group we have, the internal medicine experience you gain will be relevant to the palliative care patients you have, and vice versa. And because we know that our patients are becoming more complex, it's been acknowledged that possibly up to 3 months of palliative medicine experience would be relevant and counted towards internal medicine. But that, of course, depends on your confidence and capability as you go through. So the principles of dual training have been explained, and what I've said is they're interwoven, but what we recognise is the skills of supervisors need to be specific to internal medicine and palliative medicine. So you would have 2 supervisors to support you in those ways. And what we will be doing is ensuring that, as well as the blocks, there are days that you spend, or possibly a week at a time, with the other aspect of medicine as you go through. So those are called keeping in touch days. And we'll also ensure that you have educational opportunities in both aspects. So internal medicine study days, palliative medicine ones, procedural skills simulation, and then perhaps ensuring that you have experience of acute unselected take as you go through. We want to ensure that you know that because this may sound like a slightly busier curriculum, it doesn't mean that your other opportunities are compromised. So we're a very supportive specialty in terms of out of programme experience, whether that's for education or research. We do encourage academic training as well and have specific ACF posts that run through. We're very keen to develop your leadership and management skills because you will be taking this on quite early in your careers. And so there are fellowships for this. And then we recognise that people want to train in a way that suits them. So there are flexible training options as well. As Polly said, we've had portfolio careers, many of us, so we do encourage you to develop interests as you go through. I'm going to hand over to a colleague who's going to reflect on her own career and how varied and interested it has been.
Thank you, Kathy. Hello, my name's Carol Davis and I work at University Hospital Southampton. I've been a palliative medicine consultant for 30 years and I'm delighted to have this opportunity to explain to you why I still get out of bed and commute an hour to work. It was 1984. His name was Peter. I was the neurology houseman. It was the olden days after all. He was 30 years old, a hospital inpatient with unexplained established paraplegia. We invited the opinion of the senior surgeon, Mac the Knife, who thought that one of Peter's testicles felt slightly different than the other. He was right. Peter had testicular cancer. Even way back then, the cancer was potentially curable, yet he had a T12 sensory level and all the problems that go with that. He talked to me about his perception of his multiple losses and his fears about his cancer, his disability, and his relationship with his wife. He had symptoms that needed sorting out too. Peter, as well as my sister, who died at aged 18 of congenital heart disease, inspired me to look into a palliative care career before palliative medicine was even a specialty. And the rest, as they say, is history. I too have taken and created opportunities to do all sorts of different things in addition to my clinical work. In many ways, my career has been a bit upside down. Early on, as a registrar and a new consultant, I was very research active and well known nationally and internationally for my work on breathlessness. I wrote many papers and I lectured all over the world. Favourites were Washington, DC, Jerusalem, Trondheim, and Stresa on Lake Maggiore, which was simply beautiful. The most scary was to thousands of people in the main hall of the Barbican with simultaneous translation into 3 other languages. I've chaired international conferences, edited a book, and taken part in several debates, including the Battle of Ideas. Next slide, please. For many years, I edited the European Journal of Palliative Care and ran its case study masterclass. I wrote masterclasses myself, some with patients or their relatives, including this one. I met Lucy when she was in the early stages of pregnancy, and I co-wrote this case with her. Sadly, Lucy died just before it was published when her baby was 5 months old. I've taught a very wide range of different people about a lot of different subjects, too numerous to mention today. I enjoy pushing myself. For instance, I've met a patient for the first time ever on a stage in front of several hundred people and demonstrated how to take a good pain history from scratch in 10 minutes. 2 weeks ago, I facilitated a session, next slide please, as part of a programme called Empower, put together by our intensive care physios and OTs, with 8 people, all of whom had required intubation and ventilation for COVID pneumonia, been in hospital for many months, and are now at home. I lead a session relating to symptoms and other problems that they are still encountering after their illness and its treatment. They set the agenda. Most have a really significant symptom burden, and many are struggling with relationships. And I give them hints and tips to empower them to make things better, and I signpost to other services if necessary. I've learnt a lot, including, by the way, that foot drop and associated neuropathic pain is common as a consequence of proning. Last week, I taught on my annual slot for the King's College London MSc in Palliative Care and Policy. Nowadays, my topic is how to write a business case. The students are of different disciplines and specialties and work in many different countries. We all, including me, learn a lot from each other. The group work is presented to me and a colleague in our version of Dragon's Den. It's great fun, and the feedback is consistently that by the end of the morning, they feel much less scared about this topic. And that's really rewarding. The reason I teach this session is that I've held a lot of leadership and management roles and written many business cases. Many of the attributes of a good palliative care professional are the same as those of a good leader. Nonetheless, when I was the clinical director of cancer in our trust and was asked if I'd like to be fast-tracked to be trained as the next medical director, I thought about it and said, thanks, but no thanks. I reckoned it would take me too far away from the clinical work, which is the essence of my professional being. I've worked in all settings clinically, although for the last decade or so, just in the acute hospital, as well as being visiting consultant to the Channel Isles. I believe that a hospital palliative care team must strive to influence the care of far more people than they see. I have always championed early proactive palliative care, regardless of diagnosis, and what I call a dippy model, dipping in and out of a patient's care over time. I've subspecialised in a rather eclectic mix: cystic fibrosis, congenital heart disease, and palliative critical care. The latter was a service improvement project inspired by Les, who you can see on the next slide, in a photograph that he gave me and asked me to use whenever I talked about him. A man that we got home to die straight from cardiac ITU. The project has been a great success. The palliative critical care project has been a great success. We've evidence that it's made a real difference and have presented abstracts about it and recorded podcasts for the Intensive Care Society. The next job is to write the paper. In my career, there have been many simply amazing moments, some funny. There was the home visit alongside a CNS that I knew well. The patient's slightly smelly dog inveigled its way onto my shoulder and then, unbelievably, onto my head. I tried to pretend that I wasn't thinking, get this thing off me, and smiled sweetly, whilst the patient's wife said, "Doctor, that's lovely. Even the dog trusts you." My colleague couldn't control herself and had to leave the room. A very breathless man was sat by his bed in hospital, looking petrified and unable to talk, with his frightened son next to him. Straight away, I coached him, Relax your face, neck, shoulders and arms. Imagine you're on a favourite beach on a warm, slightly breezy day. Breathe in and out with the tide. He did just that, and he visibly relaxed, and his breathing pattern became more normal, and then a beatific smile stole across his face. After a few minutes, his son said, "Dad, what beach were you on?" The patient smiled more broadly. "And who were you with?" The patient tapped his nose and winked. We all fell about laughing. The rest of the bay and the nursing staff couldn't understand what was going on. I've learnt so much from ill people, including those that are actively dying, and in the last 4 to 5 years, particularly from patients on ITU. For me, making a difference, collegibility, and being able to laugh at myself are key. It's important to know how to recognise signs of early stress in oneself and others, and then take mitigating action. If you think that blending science, mainly physiology and pharmacology, well-honed clinical skills, and what I call artistry is for you, if you like the flexibility of being able to work in a hospice, the community, or the acute hospital, or a combination, if you're a lateral thinker, a people person, someone who will flourish individualizing patient care, there is no formulaic approach, who will relish interdisciplinary and interspecialty teamwork, and someone who will be sustained by the opportunity for lifelong learning, not just clinically, but potentially in a wide range of other fields, then a career for palliative medicine is for you. And those are the reasons why after 30 years, I still get out of bed and commute to work. Thank you.
So, hi, myself and 3 colleagues are going to now talk about why we chose palliative medicine. So first of all, I'll introduce myself. My name's Liz. I'm an ST5 palliative medicine trainee in the Northern Deanery. And I think the reason for me choosing palliative medicine was that I always felt to have a fulfilled career was variety, and training through hospital, hospices, community, and working across all specialities really appealed to me. When I started in ST3 and ST4, I really missed general medicine and missed some of the skills that I built up during core medical training. And I chose to take a year out and do an out-of program for experience in general medicine. And then coming back into training, I've been able to combine the things that I like in general medicine and palliative care, and I've been working on both curriculums. It's been really hard, but I really love it, and I'm so grateful to have had this opportunity. So I'll pass you on to Ellie, who's a trainee in London, to share her story.
Hi, so my name's Ellie Stewart. I'm a trainee in ST3 in London and KSS. I think what attracted me to palliative medicine is just the holistic approach to patient care. I came from a CMT background, so I'm transitioning onto the new curriculum. And initially I was a little bit apprehensive, having not done any acute medicine for 2 years. But I think everyone's been very supportive. I'm actually doing 3 weeks of GIM as a refresher at the moment. And I think there's a lot of transferable skills, and the general medics are actually very receptive to having palliative medicine trainees as well. And they feel that we add something as well to their own ward round. So I think it's mutually beneficial. And I'll hand you over to Sarah now.
Yes, hello, my name is Sarah. I'm an ST3 in Palliative Medicine in Northern Ireland, and like Ellie, I will be transitioning to the new curriculum in August, and after spending my ST3 year in hospice, I'm going to be moving to acute medicine for 6 months and after changeover. My interest in palliative medicine started in foundation training when I was an F1. My favourite patients to care for were those approaching end of life. It was in these situations that as a junior, I felt like I was really able to make a difference. And for me, I love palliative care because it's a specialty where there's great importance placed on communication, both with patients and their families, and it allows for holistic care to improve the quality of life for our patients. And I love how we change the focus from what the doctor and the medical team think is right to what the patient wants. There are also so many other opportunities along the way to develop other interests, and I'm currently really enjoying the challenge of considering the ethics surrounding end-of-life care. I have to confess that I probably personally would not have chosen to dual train with internal medicine. However, when I was applying last year and considering my options, I decided that I really did want to pursue a career in palliative medicine, and therefore spending some time in acute medicine was worth the cost. And even with acute medicine now as part of palliative medicine training, the ethos of palliative medicine hasn't changed, and I still really love it. Thank you.
So next slide, please. And next slide, please. So just to sort of summarise, here are some of the main reasons that we sort of felt we chose palliative medicine. So the new curriculum, so yes, for some people, they would love the opportunity to continue to dual accredit. For some people, it might not have been their first choice, and it is daunting and it can be uncertain, but I think it's bringing a lot of opportunities to us as trainees. The principles of palliative medicine, which have been touched on, so the holistic care, focusing on quality of life and what that means for that individual. I think the opportunities that are available with the new curriculum, so you might have a special interest in respiratory or neurology or in oncology, and this would be a great opportunity to explore that during training. And it's not just about dual accrediting in acute medicine, it's dual accrediting in general medicine, so it's across all specialities. So with palliative medicine, you can really choose to personalise your training. So for thinking of my colleagues in Northern Deanery, I've got 2 colleagues who are currently doing PhDs. I've got 1 colleague who's currently working in palliative care in Uganda. So it really gives so many different opportunities, and taking out of programmes for experience, for research, are really encouraged. And as has been touched on already, I think that the support that we've all had as trainees, not just from palliative medicine, but also when we're working into other general medicine specialties, has been really important during this transitional time. And I think the thing for me is that even when I did my out of programme, I realised that you never stop being a palliative medicine registrar. And the skills that you develop during palliative medicine are so applicable to those that you need working in general medicine. Decisions about escalation of care, what treatments we should do, what treatments we shouldn't do. And you take those skills with you into new specialities, and you gather new skills when you're in other specialities and take them back to palliative medicine. And it's that interweaving of the two. So I think when we got together as a group of trainees, we realised that each deanery is slightly different in terms of the rotations. So we would encourage you to contact the TPD if there's a particular area that you were hoping to apply to find out more information about training in that region. Thank you very much, and I'll pass you on to life as a palliative medicine consultant.
Good afternoon, everyone. My name is Sarika Hanchunale, and I'm a consultant in palliative medicine. Today, myself and Dr. Aileen Scott will talk to you about a day in the life of a consultant. Next slide, please. A bit about my background. So I completed my graduation in India, core medical training and specialty training in Yorkshire, and currently working on Merseyside as a palliative medicine consultant, mainly in the hospital. I work 4 days a week from 9 a.m. to 5 p.m. with on-calls. So the day in consultant's life varies. Every day is different. It would also vary from one setting to another. The day is full of various clinical and non-clinical activities, and it usually begins with handover and board rounds so that some situations can be prioritized and handled immediately. The previous slides covered how clinical activities look like. As a consultant, I'm responsible for the clinical decision-making for my patients and working in partnership with other professionals in the hospital. Just to give you an example, I've just been to HDU to see a patient and involved in a complex decision-making, and I'll work very closely with my HDU colleagues. The beauty of palliative medicine is that I can give time for my patients to listen to them and provide the personalized care. Though my job is in the hospital, I work very closely with our community and hospice colleagues through integrated service and provide clinical activities in different settings. We provide citywide on-call service 7 days a week. Coming to non-clinical activities, non-clinical activities include various areas, and some of those areas would be the area of your interest. For example, education. So education is my interest, and I'm the education lead of our department. Non-clinical activities include management, clinical governance, education, supervision, research, as shown on this slide. These activities could be local, regional, national, or international. As a consultant, we have some non-clinical time for these activities. So overall, Consultants Day is full of challenges, new opportunities, and there is a huge satisfaction at the end of the day that we are making a difference. Now, Aileen will talk to you about her work in an integrated service, hospice, and community.
Thank you, Sarika. So my name's Aileen Scott, and I'm a consultant in palliative medicine at Marie Curie Hospice in Liverpool. I'm originally from Glasgow, but I moved to Liverpool in 1997 to do a degree in politics and communication studies. But during that time, I realised I actually wanted to be a doctor. And after a false start at getting into medical school, I trained in Teesside and graduated from Newcastle University in 2007. I moved back to Merseyside for foundation jobs, and my very first job as a doctor was as an F1 in orthopaedics. One of my patients that I looked after in that first job was a lady who had metastatic breast cancer and was on the ward having had surgery for a pathological fracture of her femur. This lady was seen regularly not only by her home orthopaedics team, and I have to say that the orthopaedics consultant was extremely holistic in his care and encouraged me to spend time chatting with her and getting to know her. But she was also seen regularly by her oncology consultant and the palliative care team. And I really loved the way that the different teams worked together to address all this lady's needs and to make sure that she got good care. So I was really lucky to experience how rewarding multidisciplinary working can be really early in my career. So that's my background, and now on to what I was asked to talk about with you, which was a day in the life of a palliative medicine consultant. However, I'm afraid I really struggled to keep to the remit because every day in my job is different to the rest, as Sarika said, and in turn, every day in my job is different to every day in my colleagues' jobs. So what I will do is share with 4 real-life consultant job plans with you. And I think what you'll see is that they're all very different, but the thing they do have in common is the variety in terms of what combination of settings people work in and what special interests we've all had the opportunity to develop. So you should be able to see now the 4 posts, and post 1 is the job plan of a hospice medical director. So she obviously has a lot of managerial time, but it's balanced up with clinical work, which for her is inpatient ward rounds, reviewing new admissions that come into the hospice, attending the weekly hospice inpatient MDT, and having a weekly outpatient clinic. You'll also notice that this role has 1 session a week as a medical examiner, which is a good example of how it's possible to build a portfolio career and have sessions in an area which is separate to palliative care. I know my colleague who does this role really enjoys it and really values having something a little bit different in her working week. Posts 2 and 4 are colleagues who both work in the hospital setting, but this shows the variety that you can have even within one team. So post 2 is more focused on hospital advisory team, but post 4 has some time working in our integrated care hub, which is actually based at the hospice and supports care of patients in the community. So there's a great mix there. I think it's also worth mentioning that my colleagues that hold these 2 posts do them on a rotational basis and change kind of every 6 months so that they can continue to maintain knowledge and skills in all areas, which I think is really valuable. Finally, my own role is post 3, and as you can see, it's mainly focused on community working. So I do a lot of home visits, attend a lot of community MDTs, and provide advice and support to the community specialist palliative care team. However, I also spend 1 session a week in the hospital with a focus on seeing complex patients who are about to be discharged with the aim of smoothing that transition. And also I have a weekly outpatient clinic and also work within the hospice, supporting in the ward as needed, and again, reviewing new admissions. Some of the previous speakers have mentioned earlier the opportunities that we have to develop our own special interests. And one of my own passions is to widen access to palliative care and to encourage some of the groups who wouldn't always have seen hospices as being for them to engage with us and accept our support. As you can see, I attend a homelessness MDT, which we set up in conjunction with the GP practice that tends to look after most homeless people in Liverpool. As you can imagine, there's quite a large crossover in this with patients who use substances, so there are all sorts of complexities to deal with, but I've enjoyed this hugely as it's something a little bit different and so rewarding, and it really tests your problem solving skills and people management as you try to get other teams on board to support these patients who can be quite complex. On a similar note, one of my consultant colleagues has helped set up a palliative care MDT for patients with advanced liver disease. Often that liver disease can be due to alcohol, and there are also sort of complex social circumstances that can go along with that. And she's recently started to do a joint clinic with the hepatology team. So I think the opportunities for finding your niche and something you're really passionate about are growing all the time. And I think one of the advantages of dual accreditation is that you'll be exposed to lots of different subspecialties and different patient groups, and you'll be able to network during your training and work towards building that portfolio career if that's something you're interested in. So I guess just to finish up and summarise, as a consultant, I've managed to have a working life that lets me work as part of a team every day, which was what drew me into the specialty as an F1 all those years ago. But there's so many different combinations of what your working week could look like that no matter your interest or your passion, there will almost certainly be a way to create a job that you find rewarding and truly enjoy. Thank you.
Zacharias. I'm one of the palliative medicine consultants in Leeds. I'm going to talk to you today a little bit about future consultant posts and what they might look like. So I think sort of, as has been said already today, I hope you feel really reassured. So there are lots of consultant posts available now and will be over the next 10 years. With respect to the general medicine aspect, palliative medicine has always had a large component of general medicine. So wherever you work, learning more about general medicine really won't be time wasted. I'm a college PACES examiner and I've always considered general medicine a really key part of my consultant role. There's a great diversity in jobs across all settings in palliative medicine, as you've been hearing about today. If you are somebody who would like to work in a combination of palliative medicine and general medicine with the acute unselected take, there undoubtedly will be many emerging posts that will facilitate this over the coming years. However, it's very unlikely that many trusts will mandate GIM and acute unselected take in all of their hospital posts. Certainly, hospice and community posts will remain largely unaffected by dual accreditation. However, the most important thing, as you've heard time and time again, is that no two jobs are the same. So each area, each unit has different and evolving consultant posts. There is plenty of current and increased scope for dual site posts, so hospice, hospital, community, with increased collaboration across services. And even without these formal dual posts, there's so much scope for working across boundaries, which is really what palliative medicine does best. So, for example, I'm a hospice inpatient consultant currently, but work across a big spectrum of community providers in supporting our homelessness service. And I work really closely with my hospital palliative medicine and ED colleagues in developing our service to help patients in A&E who are dying in A&E have access to an immediate hospice bed where possible. There's also a great number of special interests, and you've heard the term portfolio career used today. So I have colleagues up and down the country who have developed special interests in certain disease areas, for example, motor neurone disease or end-stage renal disease. Lots of palliative medics are interested and involved with varying degrees of research, service development, training, working with universities, and you've heard about the medical examiner role. So within palliative medicine as a specialty, there are so many opportunities to have a portfolio to career and to develop a job plan which really reflects your passion, not just now, but in the future as well. So these things, it's a specialty where we really embrace the idea that people's job plans and people's careers and people's interests and passions evolve, as do our patients' needs. So I think it's a really exciting career, and I don't think I'm the only one who thinks I've got the very, very best job in the world. I'll hand over for questions.
So thank you very much. If you're interested in a career in palliative medicine, we would really encourage you to get in contact with your local training programme directors. Here are some contact details. They obviously will be on the slides, which will be on the PTB webpage. And I apologise to my colleague Andrew Kodabakis in Liverpool for missing him off this slide. He has given permission for us to share his email, so we will rectify that. But please do get in touch with people locally, have a chat with them, and they can fill you in a little bit more about what things are going to look like locally. So I'm going to just finish off then by thinking about some of the questions that you have been putting in the chat, and please do continue to post questions. One question I have answered immediately, which is that we have recorded this session and we will be posting it on the Palliative Medicine PTB page. So look at the JRC PTB website, click through to the Palliative Medicine page, and hopefully the link to the recording will be there. And Vicky from PTB will tell me if I've got that wrong. And then there are a few other questions which I'm going to just ask some of my colleagues to answer. I wonder if our speakers could put their cameras back on so I can see people. That would be great. Thank you. So one of you has asked about sort of general medicine and acute medicine and whether or not what the sort of interface is going to be between acute unselected take and hospice on calls. And we've also got several of you have posted questions in regard to what on call is going to look like in the future. I don't know whether one of our trainees might want to answer that as you're in the process of transitioning, maybe with Kathy coming in as well as a TPD. I don't know whether Liz, Ellie or Sarah feels able to answer that question.
Shall I chip in then?
Yeah.
So our plan is that while you're doing a block of internal medicine, then you will be doing acute unselected take. And while you're in a palliative care unit, you'll be doing the on-call for that unit. So it's not expected that you straddle from one to the other. There are, however, these keep in touch days, and one option for those is to perhaps do some acute unselected take, perhaps one day a month. But for other rotations, what we've considered is clustering those average of 12 days a year into perhaps 1 week blocks where you might work on, for example, AMU. So it's meant to be that while you've got an internal medicine head-on, you do acute take. While you've got a palliative medicine head-on, you do palliative medicine, apart from perhaps designated keep in touch sessions.
Have you got anything to add to that, Liz?
Yeah, I think that's what so this year I've been doing 4 days a week in palliative medicine and 1 day a week on the assessment suite or ambulatory care at the RVI hospital in Newcastle. My on-calls have been with palliative medicine, so our on-calls we tend to cover a hospice in Northern Dinui, and then we sometimes take calls from the hospitals out of hours as well, and we do non-resident on-calls. So although we're expected to be in the hospice each, on a Saturday and a Sunday, we're then on call from home after that. On a Friday, so I think it's because of the new curriculum, it's not necessarily about the number of out of hours on calls you do in internal medicine. It's more about it's moving to this SIPS, so this competencies based, so it's more about managing the acute take. So although this year I have not been doing any night shifts in general medicine or things like that, I've been continued to work in acute medicine and therefore build up the experience of seeing people on the non-selected acute take on my Fridays, and that's been in hours. So you can build up those skills in hours as well as out of hours.
Liz, I wonder if I can just come back to you. So Francesca has posted a very several questions in the chat, which hopefully we can cover, but she's asking specifically about about the sort of the different value systems between the kind of acute internal medicine and particularly acute unselected take and palliative medicine, and whether kind of going between the two leaves you to feel kind of conflicted. Can you be a good acute medic and be a good palliative medicine doctor, I guess is the question.
Yes. So I think one of my passions at the moment is to try and not separate them out. So you're a palliative medicine doctor and you're a palliative medicine trainee, and although you'll be working in general medicine, it's not about trying to be an acute medical consultant, although if that's something that you've got a passion in and want to do, then you could try and focus the training on around that, and the TPDs might be able to support you with that. But when I'm seeing people on the acute take, people don't have, well, people have a variety of complexity of illnesses, but not necessarily, you cannot do the job of a palliative medicine registrar assessment when you're seeing someone in an acute take, and you have to be aware of the limitations of what you can achieve in that consultation and use your local palliative medicine services. And I refer on to the palliative medicine team even as a palliative medicine registrar, but the principles of when you see someone, even if they've got a chest infection, the principles of patient-centered care and holistic care should be the same no matter whether you're working in respiratory, neurology, stroke or palliative medicine, and you can take those skills across. I think, yes, the time that you spend sometime as a palliative medicine registrar with one person, you don't always have, well, you don't have that capacity to be able to do that when you're seeing people on the acute medical take, but that doesn't mean that you can't deliver the same standard and principles of care. I hope I've not just ranted on and that makes some sort of sense.
Kathy, you were going to come out on that.
Yeah, so I work in a hospice, and what I would say is that the skills you learn in internal medicine for spotting reversibility and addressing something quickly if that's what needs to happen are very useful for a selection of patients that are now in hospices. And I have, like Polly, I do much more general medicine now than I ever trained to do. So I'm needing to hone my acute assessment skills at times and make decisions quite quickly if really somebody shouldn't be in the hospice and should be back in hospital. So I think those skills are interwoven. For me, they don't cause conflict. They increase perhaps the range of skills that I have and the things that I can teach trainees. And we quite often, well, we have an IM post that comes to the hospice as well as F2 and GP. And the comments that I often get is, oh, we didn't realise you did so much general medicine here. And I said, well, actually, yes, because people are very complex and I don't want to write them off before they're ready. You have to optimise someone's well-being and use your range of skills to do that.
Thanks, Kathy. And there's a couple of quick questions which I'll probably just take. So one of you has asked about procedural skills. So the IM Stage 2 curriculum runs alongside the palliative medicine specialty curriculum. There are procedural skills in both, but they are complementary. So you're not going to have to repeat procedural skills in palliative medicine that you're doing within or that you're maintaining competence in for internal medicine. The vast majority of the procedural skills, of which there are only 5 in the palliative medicine curriculum, are actually really driven by formative learning, and so can be done in a simulation setting and signed off in a simulation setting. So there are only 2 skills that need to be signed off in a clinical setting. So one of which is putting up a syringe pump, because you may well need to be able to do that in the community on your own. And the second one is around managing indwelling peritoneal or pleural drains, because again, they're increasingly common and you may find yourself doing a home visit or something and needing to problem solve. So those are the skills that will need to, so it's not the putting in, it's the management of the drain that would need to be done. So those are the skills that sit within the palliative medicine curriculum. And then one of you's asked about the SCE. So the SCE is for palliative medicine. There isn't a separate internal medicine SCE, but as our trainees already complain that there's too much medicine within the palliative medicine SCE, and that the reason there is general medicine in there is because we have to understand our general medicine for reversibility, a bit like Kathy was talking about earlier. So there is already some testing of medicine within the palliative medicine SCE, and that will continue, but there isn't a separate one. So there's a few other questions. One of them is, how will trainees going into internal medicine be protected from being used as service provision as registrars on the medical take, as has happened in IMT? Well, that's quite a hard question. I don't know if anybody wants to take that. I was looking at their feet at this point. I mean, I think that's when I think having the supervision is going to be really important, so we can help trying to, if you feel that you're just being used for service provision and not learning, or that it's not the right learning, that needs to be escalated rapidly to your supervisor and potentially to your TPDs. There's a lot of commitment nationally for us to be able to support you to get the best experience in training that you can have. We know already from our cohort of doctors that are already transitioning to the new curriculum that it sometimes, I think people don't fully understand that palliative medicine is dual training and what you need to get out of the blocks when you are doing internal medicine. So we're continuing to work with our IM colleagues to try and get that working better for you. So you should have a similar training experience to other doctors doing IM. It won't all be in acute medical medicine. Some of it will be in relevant specialties, like, for example, respiratory or geriatric medicine. It'll depend on the rotations. And there was a question about whether or not you'll be able to kind of rank the IM components of your training in terms of rotations. Whether there'll be a preference-based system for that. I think, unfortunately, the answer to that is probably not, because it's going to be very complex to organise. But having said that, if you've got a particular interest in a particular area, like you're particularly interested in the interface with frailty and really want to do a geriatrics post, those are the conversations to be having with your supervisor and your TPD, because we will do our best to try and make that work. But what we're doing at the moment is setting up the medicine blocks in hospitals, and there will be some flexibility, but I don't think it'll extend to being able to preference, probably because the numbers of you that are moving into these blocks just aren't big enough. And the reason that we have to deliver in blocks is because we don't run hospital wards with a mix of palliative medicine and general medicine patients, like, for example, geriatrics or respiratory do. So we can't, for the whole of your internal medicine, provide it in a completely integrated way. That's why we are having to deliver it in blocks. But as Kathy said, there is recognition that with increasing complexity in hospice and other palliative medicine settings, some of that experience will count towards IM. And we want you to think about all of the transferable skills, as Liz has already talked about. So when you're in palliative medicine, you're going to be doing a lot of general medicine and vice versa. There are a few other questions, and I don't know that I've completely been able to keep an eye on all of them, so apologies, some of them have been coming in while we've been talking. Just quickly checking through. So one of you is asking about whether training has actually been extended. Kathy, do you want to pick that up?
So no, it hasn't been extended for longer than 4 years. So the numbers changed to ST4 to ST7, and that's to reflect the fact that people will be coming in after a 3-year specialty training in internal medicine stage 1, so ST1 to 3. So ours is still a 4-year programme, of which 1 year equivalent approximately is internal medicine.
Thank you. So I think I'm conscious that we've just got 5 minutes left. There was one other question. So Alexandra's asked about whether the two curricula will be linked to each other. So on the e-portfolio, you will have an IM and a palliative medicine curriculum. But certainly you will be able to link across the curricula in terms of when you're linking workplace-based assessments and other activities, and you'll be able to, I think, upload evidence to both. So you should be able to reflect, your development as a as a doctor in training through both curricula, and both curricula will be looked at the time of ARCP. And whilst you'll have predominantly a palliative medicine ARCP, there will also be a need for you to have an ARCP for the IM component. So that's probably going to be the same ARCP. It may be two, but obviously there will be local arrangements, and we will communicate with doctors about that. So just final question. So Hannah's asked, could I be placed in a non-general IM specialty, e.g. respiratory? Would I be expected to function as a respiratory registrar? So Liz, you're shaking your head. Do you want to come in on that? Can you answer that question? Or I don't know whether either Sarah or Ellie can.
Yes, Sarah or Ellie, do you want to talk about it, or I'm happy to take it?
I don't mind either. I suppose I last year did an IMT3 year, so similar to I suppose a lot of you guys probably are doing, and I did a respiratory job as part of that. So although I suppose acted as that level, I think there's an understanding from the other specialties that we are not respiratory trainees. So I was not expected to be able to do the procedures. There was opportunities to learn how to do them, but although I acted at the role of a respiratory reg, there was an understanding that I was not one. So I imagine it'll be exactly the same. I'm going to acute medicine for 3 months and then geriatrics for 3 months. And again, there will be an understanding that I'm first and foremost a palliative reg. So I think there is an understanding that we're not going to be equivalent to the skills that they maybe have.
Yeah, that mirrors the experience that I had as well. So I think what I learned, I think it's important to be sort of quite organised when you're going into the specialties, and think, you think about what you want out of it and what you need out of it, and make sure that you have that time to be there for learning and training, rather than just service provision, because I think it can be easy to slip into wards and become, just an SHO on the ward. But I think it's important to think, right, what do I need, what experience do I need, and people are very supportive of that. Yeah.
Thanks, Liz. I think it's really key, isn't it, to make sure that you keep a dialogue going with your training supervisor, particularly in the IM component, so that you are getting the learning and training experience that you need. And as Liz said, be a bit selfish about it. So I'm going to call the webinar to a halt now, but thank you all so much for joining. There were lots of you on, and it's great to see so much interest. For any of you that are able to apply for round 2 recruitment, the recruitment window opens in mid-July. So we would obviously encourage anyone that's eligible and interested to apply, and obviously please do talk to your local training programme directors to find out a bit more about the training programmes locally, if you are particularly geographically tied or just want a bit more information more than we've been able to provide you with today. And please let your colleagues and friends know that this has been recorded and will be available to watch back in future. So thank you again very much for your time, and thank you to all of the people that have spoken today for your time. Really appreciate it. Thank you. Have a good rest of the day, everybody.